Thank you. Welcome everyone to today's Grand Rounds, where we'll have two wonderful speakers who are also from our own faculty. First up, I'd like to introduce Dr. Sarah Blank. Dr. Sarah Blank is a graduate of the University of Miami Miller School of Medicine's 6-year combined Bachelor of Science MD honors program in medical education. She completed her internal medicine residency at the University of Miami Jackson Memorial Hospital and then served as chief medical resident at the Jackson Memorial Hospital. Dr. Blank next joined the faculty at UM and spent over 10 years practicing internal medicine while educating both medical students and residents. In 2020, she took on leadership roles in the Miller School of Medicine as both a Phase 2 co-director, helping lead a major curriculum transformation effort for the medical school, and the chair of the newly formed LCME leadership team, overseeing the medical school's accreditation and continuous QI efforts. Currently, Dr. Blank leads the clinical clerkships years as the Phase 2 director and directs the practice of medicine integrated clerkship. She also serves as the Miller School of Medicine LCME faculty accreditation lead. Dr. Blank continues her clinical efforts as a primary care physician, and today she will be speaking on some important topics in the field of general internal medicine. Please join me in welcoming Dr. Blank.
Good afternoon. Thank you so much for that kind introduction. It's really wonderful to see everyone, even if it's on Zoom today. So thank you for having me. I'm excited to share some updates in general internal medicine this afternoon. However, I'd be remiss if I didn't take advantage of this platform to thank everyone for your continued teaching and mentorship for our medical students in our internal medicine clerkship, and also a slight mention, if you have any pending clinical assessments, kindly go ahead and finish those up today. But that's not why we're here. So I want to talk about a few small updates that are very recent in general internal medicine, including a recent immunization recommendation, some updated pharmacologic treatments for patients with obesity, and some hot off the presses revised breast cancer screening recommendations by the USPSTF. So I want to talk about this through the framework of how we spend most of our time, which is seeing patients. This is first case is a 67-year-old man. He recently relocated to South Florida from New York, and he's coming in to see us today because he has he wants to establish a new primary care physician. It's a history of well-controlled hypertension and COPD. His vaccinations were up to date as of his last wellness visit in April of last year, and he did receive the seasonal influenza vaccine in October. So the question is, are there any new vaccination recommendations that should be discussed with the patient today? Obviously, the answer is going to be yes. Otherwise, we probably wouldn't have too much to talk about today. So RSV is associated with up to 12% of medically attended acute respiratory illnesses in adults. So less than 1% of adults infected with RSV require hospitalization. However, RSV is still the third most commonly identified viral cause amongst respiratory viruses resulting in hospitalization. And it could even account for up to 160,000 hospitalizations and 10,000 deaths annually in the US amongst patients who are age 65 and older. So it was pretty eagerly anticipated when 2 new RSV vaccines for adults were approved by the FDA in May of last year. So based upon those approvals on June 21st of last year, ACIP recommended that adults age 60 or older may, which is an important word, may receive a single dose of RSV vaccine using a shared clinical decision-making model. So as mentioned, there are 2 RSV vaccines that are currently FDA approved for use in adults. There's one called Arexvy and one called Abrysvo. Those were both approved in May of last year. Of note, Moderna has an mRNA-based vaccine that's in development. It's undergoing biologics license application review right now. It is anticipated that this will actually be FDA approved before the end of the year. So this will likely be an update before the end of 2024. So, you know, it's interesting because it's 2024. We've obviously just been through a pretty significant global pandemic, but I think we've entered this phase of post-pandemic normalization of seasonal respiratory viruses. RSV, for example, has resumed pretty typical activity in the local community. There are some specific risk factors associated with an increased risk for severe RSV disease, which you can see listed here. Our patient, for example, has a history of COPD, which obviously is a type of lung disease, so that does carry an associated risk for severe RSV-related disease. And this is important to mention because the current RSV vaccine recommendations do advise that we consider the RSV risk factors. to advance. There we go. Okay, so this study I'm showing you here is for the Arexvy vaccine, which is the GSK vaccine. And it's showing, this was published last year in New England Journal of Medicine. It's showing the cumulative incidence of RSV-related lower respiratory tract disease and acute respiratory infection. So as you can see from the graphical illustrations here, it was actually statistically significant reduction in both lower respiratory tract disease and acute respiratory infections attributable to RSV in patients who received the vaccine versus those who received placebo. Similar results were seen in the Pfizer vaccine studies as well. So based upon these trials, the FDA again approved these vaccines. So here I'm just showing you an overview and a comparison of vaccine efficacy between the two available RSV vaccines, specifically, again, looking at acute respiratory infections here and lower respiratory tract disease here. So you can see both vaccines have a pretty good efficacy, certainly in season 1, with some retained immunity into a second RSV season. Although, as you can see, there is some attenuation from the first to second seasons. Currently, there is no recommendation in place for booster or subsequent RSV vaccination after the first one. Of note, the primary vaccine trial outcomes were RSV lower respiratory tract disease with at least 2 or at least 3 symptoms, including things like shortness of breath and cough and fever. And these randomized controlled trials included adults who were generally healthy. However, they did have some chronic conditions, but the trials did exclude those who were immunocompromised. So at present, there's no data to really comment on vaccine efficacy in patients who are immunocompromised. So here's a modeled estimate of RSV-associated outcomes that could be prevented over 2 RSV seasons per 1 million administered vaccine doses. It's important to note, these are just estimates and they're based on the phase 3 trial data. And another really key point, those phase 3 studies were not sufficiently powered to estimate efficacy against hospitalization, severe RSV illness, respiratory support, or death. So take the bottom half of this slide with a grain of salt, because again, it's modeling based on data from studies that weren't sufficiently powered. But you can see at least outpatient visits related to lower respiratory tract disease and acute respiratory tract infection could be potentially decreased by 26,000 per vaccine over the course of 2 RSV seasons. So this is a vaccine, and like any vaccine, one could expect some typical vaccine reactions like injection site reactions, arm soreness, redness, maybe a little swelling, along with the other things you see listed here. Of course, our primary concern with new vaccines, beyond their efficacy, are any serious adverse vaccine reactions. So in this case, the concern is for inflammatory neurologic events. So I have the modeling data here estimated per 1 million doses. However, in the primary studies of each of these vaccines, so for the GSK Arexvy vaccine, they included nearly 18,000 adults, and within 42 days of the vaccine administration, they observed 1 case of Guillain-Barré syndrome and 2 possible cases of acute disseminated encephalomyelitis. In the Pfizer vaccine studies, there were just over 20,000 patients enrolled. They did observe 1 case of Guillain-Barré, 1 case of Miller-Fisher syndrome, which is a GBS variant, and there was 1 patient who had an underlying undifferentiated motor sensory axonal polyneuropathy that worsened after vaccine administration. So it's low enough rates of severe inflammatory neurologic events that it's not really clearly attributable to the vaccine, but obviously this is something that needs to be carefully monitored as the vaccine is more widely used. And of course, anybody with under a history of Guillain-Barré or other inflammatory neurologic condition should probably not have this vaccine. Interestingly, for the Moderna vaccine, which is the mRNA-based vaccine, the studies are pretty much, the phase 3 studies are pretty much finished. And thus far, there's been no incidence of inflammatory neurologic disease, nor have there been any incidents of serious adverse cardiac events like myocarditis or pericarditis. So again, it is anticipated that that mRNA-based vaccine will likely obtain FDA approval and ACIP recommendation before the end of 2024. So let's go back to our patient, a 67-year-old gentleman. He does have a history of COPD, which is underlying lung disease. So the question becomes, how strongly would you recommend in favor of vaccinating? absolutely, this decision to vaccinate is based on a shared clinical decision-making discussion. And as previously noted, the consideration of risk for severe RSV-associated disease should be borne in mind. So thus far to date, again, this vaccine's been approved for just shy of a year, about 11 months now. The vaccine is widely available. Over 85% of retail pharmacies do carry it, for example. It's covered by Medicare Part B, but not Part D. So there are some coverage concerns. Private insurances cover it to varying degrees. So for the most part, this vaccine administration is happening outside the clinical offices. And I think it's clear that the vaccine is more strongly recommended for those who are 60 years of age or older and have comorbidities that put them at increased risk for severe disease, like our patient with lung disease. However, others would still benefit from vaccination because age, above 60 again, is one of the main risk factors for developing severe RSV-associated disease. However, the baseline risk of developing severe RSV-related disease and requiring hospitalization is likely to be lower in those who only have the age-related RSV risk versus those who have additional comorbidities in addition to age. As we know, RSV is a seasonal disease, so optimally vaccination should occur in the late summer or early fall, which is before the RSV season, which overlaps with flu season pretty much running from October to April. However, it's still reasonable to vaccinate at other times. I mean, we certainly see RSV seasonal disruptions. I mean, obviously during the COVID pandemic, that turned everything on its head. And the degree of protection from vaccination does appear to extend beyond a single season. So if you're choosing, you may up to time the administration of an RSV vaccine to be closer to the onset of RSV season. So again, late summer, early fall. But it is okay to give it at an earlier point in time or a different point in time. If there's a patient who's going to have some sort of immunosuppressive therapy, ideally the vaccine should be administered prior to initiating immunosuppression. And as previously noted, the trials to date, the studies of this vaccine to date have not included immunocompromised patients. So there's no clear data on the vaccine efficacy in those populations. So in conclusion for this patient, I would have a discussion about the risks benefits with him, but based upon his age and underlying chronic lung disease, he is at a risk for severe RSV associated disease. And I personally would recommend in favor of vaccinating. Our next patient. So this is a gentleman with a history of hypertension and a BMI of 37, but no other medical issues, coming to the office to follow up on weight loss progress. He's only lost 5 pounds in the past 6 months, despite following dietary guidance from a nutritionist and increasing his physical activity. His hemoglobin A1C was 5.6% 1 week ago. He has no history of diabetes. He's feeling frustrated by his inability to meet his weight loss goals and asked if there are any medical options to help promote weight loss. I think we're all pretty familiar with the fact that there is a lot of currently available medication to help promote weight loss. However, most of these medications actually carry the FDA approval and the indication to treat diabetes type 2 and not weight loss in particular. However, there are a few options that are FDA approved for chronic weight management. And the most recent one, tirzepatide, was approved in November of last year. Now, if tirzepatide sounds familiar, that's because it is. It is currently FDA approved to treat diabetes mellitus type 2, and it's branded as Mounjaro. The pharmaceutical company decided to brand the medication differently for the approval for weight loss. They are the exact same medication. It's the exact same chemical compound. It's the exact same doses. The difference between the two brand names is purely the FDA indication. I don't know why they thought Zepbound, which kind of sounds like an off-brand bus line, was the right way to go with naming this medication, but here we are. Another thing, just to kind of frame and contextualize this whole discussion, I went on GoodRx this morning just out of curiosity to see how the pricing of tirzepatide for weight management alone is currently running in using the zip code of 33136. A 4-week supply of the lowest dose, which is 2.5 milligrams sub-Q weekly, is currently priced at $1,092. So obviously some patients may have some coverage for these medications, but it's really important to bear the exorbitant costs of these medications in mind, again, as a contextualization for this whole discussion. So tirzepatide is, like many of the newer weight loss medications, relying on the incretin-based therapy. So this one's a little different though, because it is dual acting. It has both a GLP-1 and GIP agonist included in it. Both of these hormones are nutrient stimulated. They have potent effects on glucose and lipid homeostasis, and synergistic effects on appetite and food intake. So the sum is greater than the individual parts in terms of efficacy. GLP-1, as we know, is a GIP hormone. It's released after eating, and one of its primary effects is stimulating the satiety center, so we feel fuller and we stop eating sooner. GIP regulates energy balance through cell surface receptor signaling in the brain and adipose tissue. So originally in mice studies, GIP activation really appeared to act synergistically with GLP-1 receptor activation, and it led to greater weight reduction in the mice than that achieved with GLP receptor agonism alone. So therefore, phase two studies were done. They did show, again, positive results for clinically relevant weight reduction with the combo. And this class of medication has been colloquially branded the twincretins. So I think that's adorable. The twincretins together have better results than the GLP-1 agonists alone. The current prescribing guidance is to start at 2.5 milligrams sub-Q weekly, and you can increase the dose by 2.5 milligrams every 4 weeks until a max of 15 milligrams weekly. As always, with any medication, using the minimum dose necessary to achieve the desired result is always going to be the best approach. So just to talk a little bit about some of the data underpinning these recommendations, this was the SURMOUNT-1 study. It was the larger of the two trials conducted to examine tirzepatide's potential weight loss benefit in patients without diabetes. It was published in New England Journal back in July of 2022. It was a phase 3 double-blind intention to treat RCT. It had just over 2,500 adult patients enrolled. The inclusion criteria, they had to have a BMI of at least 30 or at least 27 with at least one weight-related complication. Important exclusion criteria: diabetes. Again, these are patients who do not have diabetes. Additionally, patients who had previous or planned surgical treatment for obesity were also excluded. The mean age of patients enrolled in the study was 45. The mean BMI was 38. 68% of the patients were women. The co-primary endpoints were percentage change in weight from baseline and a weight reduction of 5% or more. Patients were randomized in a 1-to-1-to-1-to-1 ratio, hope I got enough ones in there, to either placebo, which is this gray line here, 5 milligrams, 10 milligrams, or 15 milligrams of tirzepatide. And what you can see here in panel A is the overall percentage change in body weight from baseline, and panel B shows the same thing, but plotted over time, so weeks since randomization up to the 72 weeks where the trial concluded. And as you can see in both of these graphical representations, there was a difference, and it was highly statistically significant difference in percent body weight change from baseline in patients who used tirzepatide compared to those who received placebo. And there was a dose-related effect. So the higher the dose of the tirzepatide, the more significant the weight loss. In panel C and D, you can see the percentages of participants who had weight reductions of at least 5, 10, 15, 20, and 25%. So again, statistically significant difference between the tirzepatide arm versus placebo patients, and a dose-related effect was seen there. So, and just to note, like really significant, I mean, almost a 21% change in reduction in percent body weight using the highest dose. So this is really significant, and the most change we've seen from any of these medication-assisted weight loss therapies. So here I'm showing not just the co-primary endpoints, but also some of the secondary endpoints. All changes were from baseline to week 72. All the secondary endpoints were associated with greater improvements from baseline than that with placebo. Everything was statistically significant with a p-value at least less than 0.001. Additional secondary endpoints that I don't have listed here include reductions in systolic and diastolic blood pressure, cholesterol level, fasting insulin level, glucose levels. So across the board, all those endpoints did improve with this medication. So where do we go from here? There's additional studies that have happened. SURMOUNT-4 had patients take tirzepatide for 36 weeks. They achieved clinically meaningful weight reduction during that time. And then at the conclusion of that 36 weeks, they were either randomized to continue on tirzepatide or to switch over to placebo. The tirzepatide arm, and both of those were continued for a full year, 52 weeks. So the tirzepatide arm demonstrated superior weight maintenance, continued weight reduction, whereas the placebo arm did not. They actually had some weight maintenance. However, most did gain weight. So this really does suggest that most patients are going to need to use these medications in the long term. Okay, so you can see the contraindications here, the side effect and safety profile, really similar to the other incretin-based therapy. GI side effects, nausea, vomiting, diarrhea are the most common. Serious adverse events are rare and were reported equally in both the placebo and treatment groups. So just to compare some of the GLP-1 agonists, again, tirzepatide is a dual GLP-1 GIP agonist. I just want to highlight the currently available incretin-based therapies that are specifically approved for weight loss. There are 3. Liraglutide is a daily medication. So obviously patients are, if given the choice, going to prefer a weekly medication. And then in terms of efficacy, so these are not head-to-head trial data. This is just showing the primary studies on each of these FDA-approved medications for weight loss. You can see tirzepatide here does have the most clinically significant weight loss. Again, this was with the highest dose, about a 21% baseline weight reduction over the course of the 72 weeks. Again, not head-to-head studies, but the magnitude of tirzepatide appears much greater than, or at least greater than that from other agents. So it's currently considered a preferred medication for chronic weight management in patients without diabetes. Our patient is a good candidate for this medication. Just as an aside, SURMOUNT-5 is currently ongoing. It's a head-to-head comparison of tirzepatide and semaglutide in adults who are overweight or obese without diabetes. So it'll be interesting to see that comparison data. SURMOUNT-MMO is currently ongoing. So this one is looking at cardiovascular outcomes in tirzepatide in 15,000 patients with obesity with or without established coronary vascular disease. So it'll be interesting to see the outcomes for those 2 trials. As of yet, there hasn't really been a large study that's done a head-to-head comparison of medication-assisted weight loss therapy versus surgical therapy. But it's interesting to note that with bariatric surgery, usually during the first 2 years, patients can expect a 25 to 30% overall body weight loss. And with tirzepatide, that's 21%. So this is approaching the weight loss observed in bariatric surgery. Of course, in this case, with the medications, patients do need to continue taking the medications. Okay, so the last one is a very quick one. This is a 40-year-old woman without significant medical history. She got insurance for the first time and comes to the office for her annual exam. She has no personal family history of breast cancer. She's at average risk of breast cancer. And she wonders when she should start having screening mammograms performed. So this is hot off the presses. This recommendation was published about 3 weeks ago. So the USPSTF is now recommending that all women at average risk of breast cancer start screening every other year, starting at age 40. So, and that's continuing biannual screening during their 40s and beginning with everyone at age 50 as well. This is a change because previously USPSTF was the last group that was recommending individualizing the decision at age 40 and then starting for all at age 50. Every other group did not recommend waiting until age 50. As with prior recommendations, they state that the current evidence is insufficient to assess the balance of benefits and harms after age 74. There is some criticism of this recommendation because it is, even though they have lowered the age of initiation of screening, there is some who would think that it should be annual and not biannual, but that's the current USPSTF recommendation. This was updated based on new and more inclusive science. Unfortunately, more women are being diagnosed at a younger age with breast cancer, so the benefits are now outweighing the potential harm. However, the USPSTF was very clear to acknowledge that Black women are 40% more likely to die from breast cancer than white women, more likely to be diagnosed in their 40s, and more likely to be diagnosed with aggressive breast cancer. So there's really an urgent call for research to help determine if Black women should be screened on an entirely different schedule, given these worsened outcomes. And just really in general, calling for more research that will allow us to build on the existing guidance and help all women live longer and healthier lives. So the last thing I just want to show is the comparison between the major groups and the current breast cancer screening guideline recommendations. Again, USPSTF was the last group that had been recommending to wait until age 40. So now all recommend to offer at age 40. ACS says option at age 40. Everyone should start at age 45. Okay, so back to our patient. When should she get her first mammogram? The answer is now. So that concludes my talk. Some additional reading and references for anyone who's interested. So I'll pause and I don't know if we wanted to allow time for questions.
Sarah, thank you very much. That was a very nice review of three very important topical areas in general internal medicine, which are important not just for general internists to know, but all specialists as well, because clearly, if anybody participates in the longitudinal medical knowledge questions, knows these are the sorts of things that are constantly popping up on our 4-minute question, 4-minute questions. Great, thank you very much. A lot to unpack here and unravel. Each topic in its own could have lasted an hour.
I know.
But you did a fine job of summarizing. I'll open up the floor to any questions before we move on to Dr. Coffey, our next speaker. Seeing none, thank you, Sarah. That was great.
Thank
I
you.
really
I
appreciate
have a
that.
very quick question. I'm wondering, any follow-up data in the patients receiving the weight loss drug, do they regain all the weight once they discontinue the medication?
They regain a significant amount of weight, if not all of it. Initially, tirzepatide may have had a slower regain, but they do regain. So that's one of the issues with these medications, is that to see the lasting efficacy, they really do need to be continued.
Or at least, absolutely right, Dr. Bland, but one of the other things is that we hope that patients that are put on these medicines, it gives them the impetus to change their lifestyle, change diet and exercise habits, getting that positive reinforcement of having the weight loss, that then when they stop the medicine, they continue with their healthier diet and healthier habits that enable them to not gain the weight quite as much as they would have without those other interventions. So great question. And there's a lot of other work being done to how to titrate off and what drugs might be substitutes to instead of. But thank you. Okay, Dr. Osejo.
Thank you, Dr. Bland. That was a very useful topic. Next up, we have Dr. David Coffey. Dr. Coffey is an assistant professor in the Division of Myeloma at the Sylvester Comprehensive Cancer Center at the University of Miami. He earned his MD from the University of Colorado, Denver, where he also completed his internal medicine residency. He then moved on for fellowship in hematology medical oncology, where he completed it at the Fred Hutchinson Cancer Center, University of Washington in Seattle. And his research is focused on understanding the interactions between myeloma tumor cells and the immune system. Leveraging his skills in computational biology, Dr. Coffey has developed analytical techniques to investigate the cells within the tumor microenvironment using single-cell gene expression and DNA sequencing. So he aims to understand how the immune system may fail to prevent myeloma progression and learn new ways to harness the immune system's power to eliminate the disease more effectively. Today, Dr. Coffey will be providing us with a multiple myeloma clinical vignette and updates in multiple myeloma. Please join me in welcoming Dr. David Coffey.
Thank you so much for that excellent introduction. It was very kind of you. And also thank you so much for the opportunity to be able to speak to you all today. Today, I'm going to be giving you a case of an individual whom you might see in your own clinics or at the hospital that I hope is educational for you all. Let's get started because our patient is in the exam room. Let me introduce Mr. Jones. He's a 64-year-old African-American man who presents for his annual physical examination. He has a history of hypertension and hyperlipidemia. He takes hydrochlorothiazide and simvastatin. Review of systems is completely negative, and physical examination is normal. Because of his medication history, you recommend a comprehensive metabolic panel, which shows an elevated total protein. So when do you suspect multiple myeloma? Unfortunately, the symptoms of the disease are vague, and many patients will go undiagnosed for months. The symptoms may include bone pain, particularly in the back, fatigue, weakness, swelling, and neuropathy. It's not until blood work is obtained that we usually get hints that something is wrong. You can use the CRAB acronym to help you remember. C for hypercalcemia, R for renal failure, A for anemia, and B for lytic bone lesions. In this particular case, it was an elevated total protein that caught our attention. In the United States, the incidence of multiple myeloma is rising according to the American Cancer Society statistics. In fact, the state in the United States with the highest number of cases is Florida. However, if we control for population density, It's Mississippi with the state that has the highest incidence rate. The disease is more common in men and more common in non-Hispanic Blacks compared to other races. The median age of diagnosis is 69 years. It rarely affects individuals under the age of 40. Compared to other cancers in the United States, myeloma ranks number 14. Breast cancer has over 300,000 estimated new cases per year, compared to myeloma with 35,000. Despite that, it is the second most common hematologic malignancy behind diffuse large B-cell lymphoma, making it more common than acute myeloid leukemia and other blood cancers. Your risk of developing multiple myeloma in your lifetime is 1% if you are male, or 0.8% if you are female, compared to 13% for breast cancer and prostate cancer. The 5-year survival rate for multiple myeloma is 60%, which is significantly lower than prostate cancer, breast cancer, and colorectal cancer. However, it's better than lung or bronchus cancer. The 5-year myeloma survival rate is improving, though, compared to the 1970s, where the percentage was closer to 25%. We've gone a long way up to now more than 60%. As you can see in this curve, there is an inflection point around the year 2000. If I plot here the drug approvals that occurred over that span of time, you see that thalidomide, lenalidomide, and bortezomib approvals coincided with this improvement in myeloma survival. In the past 10 years, there has been an explosion of new therapies approved for the disease, and their effect on survival rates is yet to be determined. So let's go back to our patient. You recommend for Mr. Jones that he get a serum protein electrophoresis and kappa and lambda serum-free light chains to evaluate that elevated total protein in his serum. You also recommend a serum immunofixation to characterize that protein. In addition, you will order a complete blood count in addition to the comprehensive metabolic panel. And here are the test results. The complete blood count is completely normal. The comprehensive metabolic panel, I think someone has their mic on, if they could turn it off. Thank you. The comprehensive metabolic panel shows an elevated total protein of 9.1 and an albumin of 4. If we subtract those two values, we get a gamma gap of 5.1. A gamma gap is the difference between those two proteins that implies an immunoglobulin protein might be elevated in the blood. A value more than 4 should raise concern. A serum protein electrophoresis was performed, showing indeed a 4 gram per deciliter monoclonal protein. Any value above 0 is considered abnormal. A serum-free light chain measurement showed a high kappa, a normal lambda, for a skew in the kappa-lambda ratio measuring 3. Anything above 1.65 is abnormal. It's more important to pay attention to the ratio of the two values than the absolute values, as both values could be elevated with a normal ratio in infection. The immunofixation's purpose is to characterize that protein to determine its type. In this case, it's an IgG kappa. So what is a monoclonal protein? It's an immunoglobulin molecule secreted by plasma cells, also known as antibodies. Plasma cells are a mature B cell that originates in the bone marrow, travels to lymph nodes, experiences antigen, and then starts to divide in response to the specific antigen that was stimulated by and return to the bone marrow. There it will secrete antibodies that can fight infection through binding bacteria and viruses. The molecule itself is Y-shaped and has two components, a heavy chain and a light chain. The heavy chain comes in 5 flavors, IgG, IgM, IgA, IgD, and IgE, and it pairs with one of 2 light chains, kappa or lambda. Most patients will have both being able to detect in the blood, but there are some patients whom only have a light chain detectable. We call those light chain myeloma. Rarely we have non-secretory disease, where neither are detectable, making it a more challenging diagnosis as well as more challenging disease to monitor with treatment over time. The serum protein electrophoresis is the test that allows us to differentiate different proteins based on their physical properties. Here is what an electropherogram might look like. The albumin is usually the highest protein. These other peaks, alpha, beta, gamma, refer to other proteins in the blood. The gamma region and the beta region are typically where the immunoglobulin proteins may separate out. It's not so important to pay attention to the alpha, beta, and gamma numbers that are reported in the electrophoresis. Instead, all attention should be on the monoclonal protein, whether or not it's present. This will appear as a spike in the electropherogram, and that spike indicates that there's a single copy of a protein, a monoclonal protein that's present. So we bring Mr. Jones back to the clinic, and we discuss these findings of his blood work. We share with him that there is an abnormal protein in his blood, but a diagnosis cannot yet be made. We recommend he see a specialist in the myeloma service, and they recommend a bone marrow biopsy and PET scan before the visit. Here are the results of his bone marrow biopsy shown in the lower right. It demonstrates there are 40% plasma cells on the core biopsy, compared to 3% in a normal biopsy. The plasma cells are the fried egg appearing cells that have the eccentric nucleus and the blue cytoplasm. If you look carefully, some of those nuclei look like they have little dots around the edges or nucleoli, which some pathologists have described a clock face on it. A PET CT scan was ordered and it showed no lesions. However, other scans could have been ordered, such as a bone marrow MRI or a full body low dose CT. Either 3 imaging modalities are acceptable. My preference is for the PET CT scan because the PET scan does a better job at identifying extramedullary disease, which we frequently see in multiple myeloma. Extramedullary disease means disease outside of the bone marrow. Notice I did not recommend skeletal surveys. Skeletal surveys are plain films of series of bones throughout the body. They lack the sensitivity of the modern scanning, and I do not recommend plain films or skeletal surveys any longer. So multiple myeloma sits on a spectrum initiated by precursor conditions, which are known as monoclonal gammopathy of undetermined significance or smoldering myeloma. These conditions are asymptomatic and are measured and detected only by blood tests shown here. Multiple myeloma is distinguished from these by the presence of symptoms or the CRAB criteria I mentioned earlier. In 2014, the criteria was updated to also include blood tests as well as bone marrow biopsy in helping to make the diagnosis. If you have a light chain ratio more than 100 and at least 10% plasma cells, the diagnosis of myeloma has been made. If you have at least 60% plasma cells in your bone marrow, the diagnosis is made. If the values are less than these, you need to look at the blood work to evaluate if there is CRAB criteria. But if you see a high calcium, high creatinine, or low hemoglobin, that in and of itself doesn't make the diagnosis, as you need to exclude other potential causes and need to attribute those abnormalities to the myelomatous disease. Of course, imaging, as we described, can also finalize the diagnosis. So it's important to realize that MGUS is always preceded by multiple myeloma, even if we do not detect it in advance. This was shown in a publication from Dr. Landgren back in 2009, where he looked at over 70,000 patients in the PLCO cancer screening trial. 71 patients in this study were found to have multiple myeloma. And he went back and looked at historical blood samples and identified that 100% of those patients had evidence of MGUS more than 2 years before their multiple myeloma diagnosis. It was undetected. So this indicates that all patients are likely to progress from MGUS to multiple myeloma. However, the opposite isn't true. Many patients with MGUS, in fact, most, will never progress to multiple myeloma. The prevalence of MGUS is 3 to 4% in individuals over 70 and 1% in individuals over 50 years of age. So it's quite prevalent in the United States population. But here's the important part. Only 1% of patients with MGUS will actually progress to multiple myeloma. There's a higher rate if you have smoldering myeloma. But because of that, it is unclear which patients have the highest risk of actually progressing to multiple myeloma. Furthermore, it's unknown if early treatment of MGUS or smoldering will actually prolong survival. So screening is not recommended for multiple myeloma. We only recommend testing for multiple myeloma if there are clinical cues of the disease. Let's go back to Mr. Jones. He was found to have smoldering multiple myeloma because he had greater than 3 grams per deciliter of monoclonal protein in his blood and more than 10% bone marrow plasma cells. In his case, 4 grams and 40%. There are some criteria, clinical criteria, used to help further define the risk of his chance of progressing to active disease. They're called the 2-20-20 rule. He has more than 20% plasma cells, more than 2 grams of monoclonal protein. He meets those 2 criteria. If he had a kappa lambda ratio more than 20, he would meet a 3rd criteria. But because he meets those 2 criteria, his risk for transforming to multiple myeloma is actually quite high, 80% in 2 years, much higher than a standard MGUS patient. Because of this, you are going to recommend frequent screening, serum protein electrophoresis, serum free light chain, serum or comprehensive metabolic panel, and CBC every 3 months. A PET CT scan every 6 months will also be recommended, and a bone marrow biopsy annually should be performed. So it may seem counterintuitive, but the current standard of care is to wait for end organ damage. Current guidelines by the International Myeloma Working Group do not specifically recommend treating all patients with smoldering myeloma, instead rating to initiate therapy until signs of end organ damage, as I described by the definition of the disease. However, multiple studies have attempted to use clinical criteria to try and differentiate those with high and low risk disease. But if you compare all of those different clinical algorithms, you see that concordance is only 17%, meaning the agreement between these different clinical measures is poor and indicating we need better measures to try and identify which patients are likely to progress. And that's precisely what we are trying to do at Sylvester. Ola Landgren has led the study Transform, an observational study to collect annual bone marrow biopsies and blood samples from patients with MGUS or smoldering myeloma. My role in this study is to use these samples to leverage multi-omic technologies to interrogate both the tumor cells as well as profile the immune microenvironment to identify biological features that are predictive of disease progression. We believe these biological features would be more specific to individual patients, allowing us to individualize the risk of disease transformation. However, there are some studies that look at giving intervention to patients with high-risk smoldering myeloma to see if it delays progression. In those 2 studies, lenalidomide was used, an immunomodulatory drug. Both of them were placebo-controlled, and both of them found that it significantly delayed the time of progression. However, survival was not proven to be a benefit in taking lenalidomide. We believe that survival improvement is the most important outcome in determining whether or not these patients would benefit from early intervention, since many of them will never go on to experience the disease. Diko Kasanjian, another member of our institute, evaluated using carfilzomib, lenalidomide, and dexamethasone in high-risk smoldering myeloma and found that it achieved a very impressive MRD negative rate of 70%. MRD is minimal residual disease, and it's the most sensitive way that we can detect myeloma. And these patients treated with this triple therapy, 70% had no measurable disease by any technology available. However, it is yet to be determined if there is a survival benefit. At Sylvester, we are continuing along this path and enrolling patients in a study evaluating anti-CD38 monoclonal antibodies in combination with the latest bispecific antibodies These antibodies bind to myeloma tumor antigens and T cells to activate the immune system. And we're waiting on the results of this study to see if we can deepen MRD rates even further, hopefully, maybe even leading to a cure before the patients ever progress to myeloma. So let's return to Mr. Jones. 1 year later, he unfortunately develops new symptoms. He presents to the emergency department with fatigue and low back pain. His past medical history and medications haven't changed. On physical examination, you discover that he is afebrile but tachycardic. He is in obvious pain, and he has reduced strength in his lower extremities on your neurologic assessment. Here are his lab work. His hemoglobin is now reduced 7.8. His creatinine has gone up 2.5. Corrected calcium is also elevated at 13. Total protein remains high, now with a further widening in his gamma gap, indicating increase in monoclonal protein. Indeed, his SPET confirms this. It's now gone from 4 to 5 grams per deciliter. And importantly, his kappa lambda ratio now exceeds 100. Given that this exceeds 100, and we know that his former biopsy showed more than 10% plasma cells, his diagnosis of multiple myeloma has been made. IgG kappa monoclonal protein is still confirmed present. So again, back to when to suspect multiple myeloma. This patient has bone pain, fatigue, weakness. He doesn't have swelling or neuropathy, but his laboratory tests confirm hypercalcemia, renal failure, anemia, and I suspect he's got lytic bone lesions based off of his new pain. Not all patients with myeloma will present with all of these symptoms all at once. It's often more subtle. Sometimes it's just a slight anemia or a slight hypercalcemia. So you do need to do a little more work in terms of evaluating what the potential other causes of those findings are. So just to review the diagnostic criteria again, he has kappa lambda ratios more than 100, so the diagnosis has been made. He also has an elevated calcium, creatinine, and a low hemoglobin. The emergency medicine physician did the right thing and ordered an urgent MRI of his complete spine. Given his lower extremity weakness, there is a high risk for these patients to develop spinal cord compression. Around T1, we see a lesion is indeed compressing on the spinal cord. This is now a medical emergency. The incidence of spinal cord compression in newly diagnosed myeloma is around 8%. Most patients will present with back pain, weakness, and sometimes sensory changes. But back pain is such a common symptom of patients with myeloma, so that weakness is a critical component to evaluate if that is new. 70% of the cases occur in the thoracic spine, 8% in the lumbar, and 2% or 22% in the cervical. Bladder and bowel dysfunction are late disturbances. We all are taught in medical school to ask about incontinence. This is not something that typically is the presenting symptom in these patients. And importantly, treatment should be initiated immediately, within 24 hours of onset of symptoms if possible. Glucocorticoids are recommended, and referral to radiation oncology and neurosurgery during the hospitalization is critical. So here's your action plan. You're going to consult neurosurgery, consult radiation oncology. You're going to get nephrology involved given his elevated creatinine. You will consult the myeloma service. You'll give dexamethasone, perhaps 4 milligrams Q6 hours. Because of his hypercalcemia and renal failure, you'll start IV fluids and also zoledronic acid to help bring down the calcium level and also to prevent further hypercalcemia in the future. And finally, inpatient CyBOR-D will be recommended by the myeloma service. What is CyBOR-D? It stands for cyclophosphamide, bortezomib, dexamethasone. Cyclophosphamide is a chemotherapy agent. Bortezomib inhibits the proteasome in myeloma cells. The proteasome is the wastebasket of protein in cells, and that is particularly used in great quantities in these antibody-producing factories. So that is given in combination with dexamethasone, a steroid. Why do we like CyBOR-D? Well, honestly, it's because insurance will pay for it. We have many better combinations of myeloma therapies. but they are not generally approved for inpatient administration. It's also safe in renal failure. We do not need to do any dose reduction because of its elevated creatinine. It can be given IV or orally, so ease of administration. We also see quick responses in patients diagnosed with myeloma, and it can be administered once a week or twice a week, so for ease of administration. So 2 weeks later, he has completed his hospitalization and is now following up with you and being seen in the infusion center. During his hospital stay, he had an emergent laminectomy. Pathology had showed plasma cells, and his lower extremity strength began to improve a few days later, but he still requires physical therapy. His creatinine and calcium level have also improved. During the inpatient stay, he had a repeat bone marrow biopsy showing 95% plasma cells with deletion 17p, encompassing the p53 tumor suppressor gene, as well as amplification of 1q with numerous oncogenes. These are some of the most common abnormalities, cytogenetic abnormalities seen in multiple myeloma that portend usually a more aggressive, resistant type disease. He completes 2 doses of Cyborg-D before he left the hospital, and now he is scheduled to discuss his next line of therapy. So for induction therapy, which is the first therapy we give patients with multiple myeloma, we are now starting to see emergence of good data supporting the use of quadruplets. That means 4 drugs to be given at once. In this recent New England Journal of Medicine publication, triplet therapy was compared to quadruplet therapy in 709 newly diagnosed myeloma patients. The quadruplet therapy was an anti-CD38 monoclonal antibody combined with a proteasome inhibitor, an immunomodulatory drug, and a steroid versus a triplet that did not have the antibody therapy. And we saw in this study a progression-free survival benefit for the quadruplet, 84% at 4 years compared to 67% in the triplet arm. However, there were more serious adverse events in the quadruplet arm, as would be expected. However, importantly, there were fewer adverse events that resulted in treatment discontinuation. So while there were events, they usually were mild enough that the treatment could be continued without having to make a change. So the natural history of multiple myeloma is that of a relapsing and remitting course. Patients will have multiple relapses throughout their disease that will require subsequent lines of therapy. In fact, patients with myeloma will require lifelong therapy. Rarely can we discontinue treatment. Our goal usually is to achieve minimal residual disease. That is the lowest amount of disease our technology can detect. If patients can dip below this level, usually they have a longer progression-free survival and overall survival. So it's an important milestone for all myeloma patients. In the past 10 years, I mentioned there has been an explosion of new therapies for multiple myeloma. Here's a menu of just some of the treatments that we have to choose from. Many of the therapies are heading towards immunotherapies. Immunotherapies are ones that activate the immune system to target the myeloma cells. And we currently have 4 classes: monoclonal antibodies that bind to myeloma antigens on the surface of plasma cells, bispecific antibodies that bind to myeloma surface antigens and T cells to activate the immune system. We also have chimeric antigen receptor T cells that are genetically modified autologous T cells that activate the patient's own immune system directed against the myeloma. And finally, the immunomodulatory drugs that stimulate effector cells and suppress the regulatory T cells. So in summary, multiple myeloma is a plasma cell neoplasm characterized by an elevated monoclonal protein and evidence of end-organ damage, which you can remember by the CRAB acronym: hypercalcemia, renal failure, anemia, and bone lesions. Recognizing CRAB and then ordering the subsequent tests, serum protein electrophoresis, free light chain, and immunofixation in particular, are the first step to confirming this disease. Any treatment delay has serious consequences, including paralysis, pathologic fractures, end-stage renal disease, and even death. Our research at Sylvester aims to identify patients who are at the highest risk for disease transformation to myeloma and who would most benefit from early treatment intervention. Here's a picture taken a year ago of our myeloma team. We have 7 faculty as of today. Later, we will have up to 8 faculty this year. And some of our research staff are shown here. We probably doubled in size since this picture was taken. And I want to thank you all for your attention. Please consult us on any patient in the hospital with multiple myeloma. We want to be involved in their care. And thank you again.
David, thank you for this beautiful grand rounds. This was really eloquently stated, very didactic, very clear, and definitely appreciated by me. Thank you. If someone were to ask, what's the role of bone marrow, at what stage does one consider bone marrow transplant in patients with multiple myeloma in order to, and is that useful even to prevent the undulating process?
That is a very important question and very pertinent question. I came from a transplant center, in fact, the first center to offer auto transplants for myeloma. So while I was there, the philosophy was any patient with multiple myeloma should be offered a transplant if they are otherwise healthy and don't have major comorbidities. However, things are changing. In the age of quadruplet therapy, as I've shown you in the New England Journal paper, we don't know if autologous stem cell transplant is still needed for every patient. I think additional studies need to be performed, comparing patients with the quadruplet therapy to transplant or no transplant to see if that is still a requirement. But as of today, 2024, I would still recommend a consideration of autologous transplant to all of my patients.
Thank you. Laz, you have a question you want to?
Yeah, thank you, Dr. Weiss. David, fantastic presentation. My question is, recently the FDA approved the ciltacabtagene cilta-cel, the autologous CAR T against BCMA for even patients who have failed only lenalidomide. So now it's on the second line. And here we don't see so many referrals for CAR T from your group. I have it as a little complaint. But do you think that the practice will change after this FDA approval?
I think CAR T cell therapy has been very challenging for myeloma because of the long wait lists for patients needing the therapy. If I referred to you a dozen patients next week who have failed lenalidomide, it would be unlikely that you could offer them all treatments because of the need to manufacture the product and the delays associated with that. So I think that it's partly related to the manufacturing delays and the company's ability to keep up with the demand that may have been the reason for fewer referrals. But now that we have FDA clearance to give it even sooner, I hope that the company is prepared to be able to ramp up. In your experience, do you think that they will be able to match the demand?
And they are getting better and better, and they give us more slots. And I believe it's the most impressive salvage therapy for myeloma that I have seen in my life. You see undetected proteins, period. You don't see them in samples.
Yes.
Well, I thank Drs. Bland and Dr. Coffey for an excellent grand rounds. Thank you very much. I refer everyone to the chat in order to get the link for the CME and MOC credits. I wish everybody a wonderful and safe day and look forward to seeing you next week, if not sooner. Thank you and be well.
Thank you, sir.